Welcome to this evening's meeting of the Health and Wellbeing Board, and thank you everyone for joining us this evening. As you can see from tonight's agenda, our focus continues to be on our collective response to the COVID-19 pandemic. I think reflecting on the fact that today represents what is a particularly tragic milestone of 100,000 lives lost across the UK. But I think importantly, what we'll hear this evening are some points for hopefully for optimism around both testing and progress with vaccination. And we'll also hear about some of the work that continues to progress away from COVID-19 around our sort of collective ambitions to deliver a healthy place across Merton. So first up on the agenda is apologies for absence, and I think we have Dr. Aditi Shah has sent apologies, and also Dr. Mohan Zekaram for lateness. Second is just around declarations of pecuniary interest. Are there any interests? Just scrolling through, I can't see anyone. And then lastly, before we get into the meat of the agenda, is just around minutes of the previous meeting. So can I just take the minutes that we have as an accurate record? I can't see any dissent, so I will hand straight over to Dagmar to provide us with an update on the situation in COVID, in addition to an update on testing and restrictions. Dagmar.
Right. So good evening, everybody. And I think, Clarissa, you're helping me. I've got a few slides as usual. Super. So if you move us to the slideshow, and then the first slide, please. Thank you. So the summary messages, I'm really delighted. They are actually more positive. So all the indicators that we particularly worry about, including our infection rates, are now on the way down. Really important, you can see at the London level as well that the R value, which you've heard is a really important measure of whether the epidemic is shrinking or growing, is now gone down a bit of a tentative between 0.9 and 1.2. And for us, as usual, really important, we look at the infections overall, but also to the over 60s as the most vulnerable, and that rate is also climbing down. And then, as Rebecca, you mentioned, it is a tempered optimism, because there are still quite a lot of pressure in the NHS, and obviously the deaths, as we've discussed before, they normally lag behind, and we see that in Merton. So we've got high weekly COVID death rates now. The figure you see, 33, was the previous week. I've just got our new ones, and at least it is not climbing anymore. So for this week it's 32, but these are stark numbers, and clearly the real harm of this pandemic visible. So if you move us on. We are, and I won't dwell on these slides, you know them now, they've gone all colourful, which indicates to you that things are on the change and on the move. The tiles are the other London boroughs, where the arrow is Merton, and as I said, it moves in the right direction, and it moves in the right direction for the whole of London, albeit at a slightly different pace. The next set of colourful tiles shows you our testing rates, and that again reflects that I said we are optimistic, but we are tempered optimistic, because we still have high rates and we still have high positivity. So when we look at tests, and our testing is going down, so there's a little bit of a crunch, and for you as the members of the board, we cannot reiterate enough the importance for even the mild symptoms going to get tested. And then the next slide, as I said already, This is the impact in the NHS, and our partners will talk a bit more about it. But so still very, very busy. You can see the occupancy at the bottom left-hand corner. Still a lot of severity in the hospital, that's the right-hand corner. But at least admissions, new admissions are slowing down now, but those who are in hospital stay and are very sick. So the NHS still under a lot of pressure, but it's looking up. I've got a few next slides more focused on some Merton analysis, if you move us on. So that is the, in a way, sad but really important tracking of our COVID deaths. You can see they've climbed up to 301 now. And what I wanted to draw your attention, there's obviously always the ugly first wave, and luckily we are nowhere near that peak at the moment. But what you can see, and I haven't got all the answers, but we're looking into it, is that our COVID deaths are going up, but also our non-COVID deaths. So there is the excess mortality. And if you look back on the first wave, and we had numerous questions about that, there is this really ugly spike of non-COVID death as well. So that is something that we are trying at local level, but also with our London colleagues to unpack a bit. But as you're aware, more detailed information on our deaths takes a little while before it comes through. If you move us on. I won't dwell on this. We're obviously looking always at infection rates in our neighbouring boroughs, and we're all coming down, albeit at slightly different pace. If you move us on. This is an important slide. This is about outbreaks. And you can see we are not twiddling our thumbs. We're indeed still very, very busy. That reflects the general still high rates. And it's interesting that lots of activity in our care homes and adult social care settings, but more recently indicating that our schools, albeit closed, are still open for key workers and vulnerable kids. And we do see outbreaks there as well. So if you move us on. Here is an example that we're always trying to understand more granularly. Where are the infections, who is infected, and on the left hand side it shows you the breakdown by age groups. And so it shows you, for example, that in the working age group 45 to 59, it's not rushing down as much as we wish, and there's also a little upturn in the youngsters. So as I said, tempered optimism, but all of us, we have to hold it, that we don't get too excited too soon. We are not yet safe. So as the CMO said, it's precarious. And I think on the right hand side, very important for us as the Health and Wellbeing Board, a bit more of a geographical spread of where our infections are, and I will show you more slides. It is now clearly more in the east than the west, and that has obviously implications for the Health and Wellbeing Board and our real ambition around protecting the most vulnerable. So if you move us on. Therefore, and I think, Rebecca, you suggested that early on, very rightly, we keep a closer eye now on ethnic data. And again, what you can see, there is now a much clearer signal that the non-white groups have more infections. And this really has only taken off over this sort of last period with the new restrictions. If you give me the next slide, I can show that to you. So this, I think, is quite a telling slide, because it shows us the infection rates in the east of the borough red and in the west. And when I last spoke to you, I think we were on the left-hand side, where the two curves were crossing over each other. And there were times when the west was heading in front of the East. But then you can see when the new tiers were introduced and at the lockdowns, and obviously we're asking ourselves, so what are some of the underlying drivers? And for me, the right-hand side is really striking. So the hypothesis, the strongest hypothesis are jobs. So people that can work at home are those much more prevalent in the West than the East. And if you look at occupations and exposed occupations, there is a clear differential. And then it's very interesting, we looked at the bottom is overcrowded households. And if you show us the next slide, these are the age differences. And so for me, it was quite unexpected that in the East, the older groups were so much more affected. And again, the hypothesis is that it's working age groups and the older groups because of the housing, and the working age because of the jobs. So that are messages, again, at the moment, only hypotheses, but for us as Health and Wellbeing Board, really important messages. If we move us on. So that is very briefly, so we're thinking amongst our sort of COVID tools, what have we got? Obviously making sure that people who have symptoms have no issue in terms of accessing the tests. And as we know that we have particular infections in the East, we constantly check, have we got enough testing capacity in the East and are they accessible? So if you look at the left-hand side of the slides, it shows you what's the preferred method of residents across the whole of Merton, and it shows you, and it makes a lot of sense, it's the home testing. And then the second is our local testing sites. And then the right-hand side shows you where most of our testing activity happens. And at least there is some match with our infection rates, so more in the East. If you move us on. These are our local testing sites, so anybody can book on them, and it shows you what I've mentioned before, my slightly tempered enthusiasm, that I feel our positivity is still pretty high, but our occupancy and activity in our local testing sites have actually plummeted quite a bit. That looks a bit premature to me, so we have to absolutely keep promoting the testing. And then finally, this is a slide where we're trying to look about specifically around access to testing through different ethnic lenses. And you can see that there are some mismatches potentially with Asian groups having more positive tests. And so we need to make sure as there are less testing, that when we promote through our networks, we tune in particularly with those community champions to find out whether there's anything else we can do to ensure that those who need it get a test. So that's, I think, my slides. Now, there was also the question for me very briefly, I think, to give you a very brief update on where we are with asymptomatic testing. Apologies, there were meant to be 2 summary slides. They have somehow fallen out of the deck. So what I suggest, Chair, if you allow me 2 quick minutes for an update, and then Clarissa can add the slides as a reference to the minutes. Subgroup has done really quite an in-depth discussion around asymptomatic testing, so I just give you the flair. As you will be aware, the asymptomatic testing, the aim really is to find people who haven't got symptoms but carry COVID. The reason is that we know 30 to 40% of COVID is asymptomatic. And if you find those people and they self-isolate, then you break transmission. And so we have developed a program, And the target for our asymptomatic testing are frontline workers that are exposed and that cannot work from home, but keep us all going. So we've got various settings and groups, and we work very closely with a national program as well. So some essential workers that are out there are supported nationally. So our care home and adult social care staff, they get their tests already from a national program, but we support. Our schools are doing the testing because obviously, although closed, they are still providing a service. The NHS has its own lateral flow testing system for all their frontline workers. So we are now focusing particularly on the voluntary sector, on carers, and what we are providing is one is a site in Merton, and I hope you all have heard Morden Hall Assembly Hall, where frontline workers can get a test. And we have got a whole range of community pharmacies. They are growing as we speak. I think we've got 12 now, dotted all over the borough. Again, where we're inviting for asymptomatic testing. The normal regime is for frontline staff to have a test twice a week. And I'm glad to say we had to scramble, get it off the ground between Christmas and New Year. These things happen, but it has embedded well now over 1,000 tests per week in the Morden Hall Assembly Hall, and another 1,000 in the community pharmacy. So it's something for you to promote. It is not walk-in, it is for booking, and that is purely for safety reasons. And we're now working out with our Chamber of Commerce, with Love Wimbledon, to also include essential frontline private businesses, so drivers, transport, taxi drivers, small retail. And again, the subgroup works on that and supports us to extend the testing. That's a quick canter through and open to questions.
As always, Dagmar, thank you very much for such a useful update. I appreciate how much work and time both you and the team put into this and presenting it back to us. And as you say, sort of tempered optimism since the last meeting of this group, but particularly potentially even some worrying challenges in terms of cases in the east of the borough, and particularly amongst Black minority ethnic groups, which I'm sure colleagues may wish to pick up on. So could I just open to questions for Dagmar? Ellie.
Thank you so much. Thank you, Chair, and thank you so much, Dagmar, for all that work. I was really struck by the slides on the East and West split by age, and you were very clear that there were only hypotheses as to why there was a difference. So, but what struck me was, so it looked like in the West, the 0 to 15 and the 16 to 29 groups were higher than in the East. But lots of those people who are older in the East do live with young children. So are they not, is this more evidence that those young children aren't getting it? Or are you just going to tell me it's too cautious and we can't say anything?
Yeah, so it's open to ideas, and I think what you're doing, generating hypothesis, we like that, because that's helps us to look at how could we look at data to find answers. I am not sure about the exact role of the small children in the family. You will have heard about the research in that probably the transmission from smaller children into families is not that dramatic, but that we know that older children are transmitting as adults, and probably, although I don't want to stereotype, the social distancing might not always happen, particularly in and around school, very difficult with a more transmissible variant. So there the transmission is going on. But for me, what I hadn't expected, to be honest, on this one was the older people. And that's where I said dust down the overcrowding. Now overcrowding isn't the same as intergenerational living, so I'm jumping there as well. But it is something to look into, and explore.
Rob, did you have a question?
Do you know what I did? And I didn't even raise my hand, so somehow telepathically you knew, Rebecca. Thank you. Just a question about that reduction in testing, Dagmar, and whether that's the experience seen in other boroughs around London, that kind of people actually accessing the tests, and whether there's anything we could learn from other boroughs where that might not be the case.
Yeah, so are you, Rob, just double checking, we're talking about the PCR testing, the decline in the PCR testing. Yeah. So it was, if you go back to this slide, we don't need to flick back, but when you look at the pack, the London tiles I added in, and they were the blue ones. So you will see that there was actually a decline across London. Some boroughs more than others, but the general direction is the same. And the positivity also is hanging on, and the testing is going down. So again, quite a number of potential explanations. One is that there was a flurry of testing before the holiday period. Yeah, so that was almost like an unusually high peak, rather than us now going down. And the second, that people are getting fed up with it. And as they're now having to stay home and are in lockdown, and if they only have mild symptoms, there is anecdotal evidence that people say, let's just stick it out, because it won't change much of what we're doing. Now, we need to, again, that is anecdotal. We try to push to say, do get a test. Yeah, we don't say for people, don't travel for an asymptomatic test, don't use public transport, that is disproportionate. But if you are symptomatic, we recommend home testing, obviously, is the best. But if you want it assisted, then go preferably to a local testing site.
Thank you. Mohan.
Thank you. Thank you, Dagmar. Thank you, Chair. Just a couple of comments, really. Interesting to see that 86% were new variants. That's will certainly tell, won't it, what that means to all of us. And it's good to have the breakdown for the ethnicity for the testing. It would be kind of whether we could get the data for the mortality for the ethnicity, and also the vaccination uptake by the ethnicity as well. That might, I don't know whether that's possible. I think we're trying to get that through Pinnacle, and that's certainly been part of the new data set. Interesting about the levels as well. Certainly the East and the West were sort of hugging each other as the first wave went, and then the second wave's coming now. There's that sort of big sort of split, isn't there, between the two? You know, whether that addresses health inequalities or whether there's other factors which you've touched upon. And actually really interesting is, as Eleanor was saying, about the older generation in the East. And obviously we know that the East normally has younger, ethnically diverse population, and the West has older population. It seems to have swapped. So yeah, really fascinating. And certainly one thing we're kind of working on at the moment is vaccine hesitancy, in terms of getting, you know, patients from BME backgrounds, trying to get them to uptake the vaccine. And certainly there's lots of webinars happening at the moment across the borough, which is great to see. So yeah, just a couple of comments and observations. Thank you.
Shall I just very quickly come back on the ethnicity data on deaths? Absolutely, and you will have heard there has been quite a lot of push after the first wave. And there was even an attempt to say, can the registrars be asked to take ethnicity when they register the death. That hasn't come to fruition. So what we have is the very annoying lag. I can tell you how many deaths I've got per week. I get that from ONS. I can tell you where they have happened, but I've neither got the age nor the ethnicity. Yeah, so that comes, it will come, but it comes with quite a lag. So watch that space. And then in terms of the vaccine debate, I'm glad to say that's on the agenda at full speed. I think our NHS partners will cover it, and then we have got an item particularly on how we work with a subgroup, what the subgroup will do in the future, and we cover it there.
Excellent. Actually, one thing I did want to ask Dagmar is we are doing a webinar this weekend. Bass is joining with a couple of other BME doctors and public health. I think Una's coming along with the pharmacists as well. We're going to do a talk, and I wonder whether I could use some of that data. So I'll to sort of just showcase where we are at the moment, what COVID is doing, and actually answer some of the myths or talk about what can be done. So yeah, I'll put you on the spot there, but yeah, thanks.
Brian, did you want to come in? Sorry.
Yes, it's a quick one. I may have asked it last time we were here. Is there any measure, Dagmar, of I think we termed it collateral damage the last meeting of, I mean, fairly obviously with the focus on COVID, we know that there are a lot of non-COVID patients not getting procedures and examinations and the usual sort of stuff. Is there any objective measure, might be for Mark this, you think there'd be a bow wave, wouldn't you, of these people that are just following on from the COVID figures? Is there any data actually around?
Yeah, so I think it's a really good point, and in its harshest, it is the excess death that I showed you, that are actually on that slide, not COVID. We have got extra death through COVID, but we've actually even got more to non-COVID. Brian, it's a whole bucket of different things. Yeah, there is very likely, and again, we haven't got all the hard and fast data, but we have got the learnings from the first wave, and it is most likely that we have at least partially a repeat. So part of it in the first wave was less access to the NHS. Now, on the second wave, it was a real strong attempt to give a very different message, and the NHS did not close down. But I will refer to our NHS partners, and it is something we will look at. But there are obviously other non-health collateral damage that can translate into health and well-being issues, like the economic damage. Yeah, so economic damage can be existentially threatening, deteriorating mental health, etc., etc. You will have heard from the first wave reports around more, at least para-suicides, probably also suicides. The data are still collected, and that is at least partially the really strong societal stress. And if we refer to our children's colleagues here, there are some really stark and quite distressing data coming out around harm in our babies, and referral for safeguarding. So generally, the whole situation that COVID has thrown society in has created a lot of potential reasons for additional death. And so much more analysis will come. So I won't leave you alone for a long time. I will bring you data.
Thank you, Dagmar. Vasa.
Thank you, Chair. Thank you, Dagmar. And I think what you said is very important. It is very tempting when we reach the sad landmark reach today to look at death as the only measurement. And I think I was speaking to Andy Otley this morning, long COVID. Andy is more than happy for me to talk about it. A GP in Cricket Green, he says by the time the evening comes, because of long COVID, he just has to go home. And he said, he sent his apologies. And I said, withdraw your apology. You're not required to attend this meeting. You have got long COVID, you're recovering from it. I got his permission to talk about it because I said to him, no one on this forum here expects you to come. You get better and you come back. At the moment, he goes to work at 8 o'clock. He says by 6 o'clock, he says he just has to go home. And I say, well, drive safely then. There's no need for you to come here. And we need to appreciate the consequence of COVID on our workforce, be they clinicians, be they teachers, be they porters, be they cleaners, be they whoever they are. We have to look after them as much as we look after veterans who came back after the war. This is our war. And when we recover, we need to appreciate that we can't expect the system to rank up and rave up and gear up and all the fancy words management technologies to throw at us. Our workforce are human. Bricks and mortar, you need cement and you need bricks. You can build what you want to build. But the humanity behind the system, which keeps the system running, we need to take heed and take note. And we really need to make time, give space for people to recover. And we need to look at the whole picture. And therefore, we go back to the prevention. And to me, the prevention becomes the key. And we got to understand that I can heat my house, leave my window open, and get the ventilation done. Others will say in the middle of the winter, you must be joking. What will it do to my heating bill? And then these are the soft factors which may actually contribute to the east-west divide. Obviously, I live in Merton, and you probably would know that I live in the west of it. But I think we need to look at the impact of congestion. There are only 2 adults in my house, me and my wife. And that is the reality of life we face, and that is the inequality of life we face. And the burden of COVID, the burden of long COVID, the impact in mental illness is going to be visited upon the parts of Merton differently. And we need to prepare in the short term and in the long term. And in the short term, the biggest thing we can do if we want to save our population is to get out the vaccination message. And we really have to walk the streets for that. We can't sit in our comfortable chairs and achieve that. And I think the single most important thing any one of us can do for our citizens and our system is to get onto the vaccination agenda. That is the only thing I would say we should really, really be talking about and focusing on, because you know what? The people who need it the most are the people who are getting it the least.
Thank you, Bessa. And I think you raise a really important point about sort of inequalities and those wider determinants of health. And I'm really glad that also on the agenda, we are going to be talking about sort of a climate strategy later, which of course all these things contribute. Mark.
I suppose just building on Vassa's as well is, and Dagmar's comments, is that one of our messages is still very much the NHS is open. So if there's an emergency or there's an urgent care need, please do access the NHS because we are still there. And as well as the acutes being very busy, they also are treating quite a lot of non-COVID as well. And actually they are focusing on really kind of high priority cases such as 2-week cancer waits, etc. So there is good progress behind the scenes. Brian, I don't think that's the totality in any way, but it's just to say that, you know, our trusts are also doing non-COVID work and trying to kind of focus on priority areas. But the message is, if you've got an urgent need or an emergency need, please do access your NHS.
Thank you, Mark. Do we have any last questions for Dagmar? Okay, could I, Dagmar, just ask one question? I think we're obviously in sort of a national lockdown, and just picking up on the points you made around lateral flow tests or testing for people who are asymptomatic. And I know really critical value for sort of key workers, volunteers, carers. And I just wondered what your advice would be, or your message for residents who are working from home, for example, who are only going out for sort of essential reasons. So whether or not we'd sort of be encouraging lateral flow tests for sort of residents from that perspective, and just your view on that.
Yeah, so I have never made it a secret that I never bought into the mass testing. It was a legitimate sort of idea that we might get on top of it if only we test everybody and we do it in one big swoosh. I think there's enough learning from Liverpool that did not deliver the goods. So our asymptomatic testing was always a targeted, purposeful testing. And I feel in a way justified now, because I think that is much more the accepted policy now. So I would not actively encourage people to say if they work from home to get out and get a lateral flow test. But I also would say let's empower people and let them decide. So if they, for example, where, I'm making this up now, went shopping and felt somebody in the aisle was really coughing and they felt uncomfortable, they can then now say, was I exposed, was I not exposed? There is the option of a lateral flow test, even though I haven't got any symptoms. So just trying to work and say there is the opportunity, but you need to understand what it's for, what it's not for. And the purpose mainly is the regular testing for those of us who have to be out there. So those in the shops that have to serve the customers, to do it regularly.
Thank you, Dagmar. And just before we move on, Chris, did you have a comment? Oh, Chris, I think you might be on mute.
Sorry, schoolboy error there. So it's just to come back on Brian's point around collateral damage, and just to pick up on the impact for those who survive COVID will really be much longer term. And I'm talking here about the business and economic impact of COVID, because we're in a slightly unusual situation now with all of the support for business and individuals propping up the economy. The full longer term impact won't be known until probably later this year and beyond, for those who lose their jobs, where the businesses collapse, and the mental health consequences in particular of that in the borough. We'll need to keep a very close eye on. We work very closely with the Chamber of Commerce. I had a meeting with the Chief Exec of the Chamber earlier this week, and they were quite positive about the businesses that are continuing to sustain their position at the moment. And the number, for example, of businesses that are dropping their membership with the Commerce was very small. But they're all being supported by government funds at the moment, and Merton is very good about getting that money out to the businesses. The numbers who are going on universal credit has increased, and the numbers of staff who are furloughed is clearly very significant. But it's an area that, as a council and as a board, I suspect we'll want to keep a very close eye on, because we will fall off the edge of a cliff, or there will be a very significant downturn when that support is withdrawn as we come out of COVID, and we really see then the scars on the economy and the businesses that don't open their doors again, and the numbers who stay on universal credit, and the complete change in the employment picture and the sorts of jobs that used to exist that no longer exist, and then the impact really on mental health and the consequences of that.
Thank you, Chris, and a really important point there. And thank you also to Dagmar for presenting back to us. I think just sort of on that agenda item, we're sort of being asked to note, but I know it's something that naturally we will discuss at our next meeting and ongoing. And just moving on to the next agenda item, which is an update on from the NHS on COVID-19. I'm sure we'll sort of kick off with some of the really positive news around the vaccination programme. So I'll just hand over to Vasa and Mark to pick up on that.
Okay, so I'll start, but just in terms of, there were three things that we were going to update you on. Firstly, just the acute and hospital kind of the situation there. Then I think about the vaccinations, and I think there's a presentation that we have brought along with us and that can certainly be distributed around the vaccination. And then just a little update on the Integrated Care System Next Steps paper. And perhaps I take that one first, because the engagement process has finished, and we're waiting to find out what the feedback from that will be. So in some ways, we're kind of just waiting now to see in terms of the engagement process, what was the outcome of that, whether it changed any of the options appraisal. The only thing that we're really doing is we're talking about place, we're talking about Merton and how can we strengthen our health partnerships, how can we strengthen partnerships with our local authority colleagues and with our voluntary sector colleagues. And we have a great platform with the Merton Health and Care Together that we can absolutely do that. So that's probably that update, because there's not really that much to say. If I then move on to the acute, acute, as Dagmar said, really busy. On any given day, it can be a bed capacity issue, it can be an ICU capacity issue. And the nature, I think, of the pandemic is that changes on a very daily basis. So actually one day you can be looking at ICU capacity and the next it's, I haven't got enough non-COVID beds. That said, the South West London trusts, and particularly St George's, I have to say, have been managing this really well. And there's a kind of mutual aid and transfer that's talked about on a daily huddle every morning, and I've been doing those daily huddles. It's fascinating to see how the acute sector can really kick in and support each other. But one of the big challenges is absolutely staff shortages, and that's just having enough nursing staff, enough clinical staff to actually treat people in ICU and in the non-COVID wards. That said, it'll be of interest to the board that there are 60 Army support workers that have been brought into St George's, and there's Army support also going into the Wilson and the Nelson vaccination sites as well. So we are bringing in both volunteers and other services to support. There's been lots of reports about oxygen issues in South West London. There's no oxygen issues. Each trust has oxygen. And just as I was saying earlier, the trusts are also focusing on priorities, priority areas such as cancer, people, etc., to get them through so that they are seen, treated and cared for as quickly as possible. What are we doing about the kind of pressure in acute hospitals? We've got a range of initiatives underway. We've got something called home oximetry, where people can be monitored remotely and at home, and that they can be done that via primary care or secondary care. We've established a bed bureau. So actually across South West London, if anyone, any trusts needing to transfer someone who is relatively stable but not quite ready to go home, we have bed capacity at their disposal. We've established some neuro rehab beds as well, so that's a cohort that we know we're having problems discharging. We've got, you'll know that the temporary alternative discharge destination, TAD, which the first one was in Merton. There's now one at the Teddington Hospital, and we are talking to Sutton about Sutton Court also becoming on stream. That's really pertinent to Merton, because actually it's our Merton clinicians that will be supporting it on a day-to-day basis. So I'll just mention that. And just to say that in terms of, we've developed an enhanced discharge program. So we've got GPs working clinicians to identify those patients that perhaps would have stayed in hospital for a few more days. They've got a slightly higher acuity, but we're bringing those home with primary care providing the care, but with secondary care oversight and advice and guidance. And that's basically, we're calling it a kind of virtual ward, but we're doing really good work there. Picking up on Vasa's comments, there is also long COVID services, and they might be respiratory services, they may be diabetes services, they may well be mental health services. So we're working through a number of different pathways to support people who have had COVID. Just in terms of discharges, I just do want to shout out to our local authority colleagues, and particularly Hannah and her team, because the feedback from St George's is just that across Merton and Wandsworth, discharges are just going really well, and it's really supporting St George's in managing their capacity. And that really is a joint piece of work which is going brilliantly, and I just want to give thanks where thanks is due to, so thanks to our local authority colleagues. So I'll stop there in terms of the acute and take any questions, and I think Vasa wants to say something.
Vasa, sorry, I think you're on mute.
Thank you, Chair. I think, Mark, it's important for us to provide reassurance to the forum how seriously we take both TAD and discharge charges. No one comes out to a TAD unless there has been a prior clinician to clinician, therapist to therapy agreement that that person can come out. So there is a right, there is a visa system, there's a passport system here. No one is sent out without everybody agreeing that that person comes out. Similarly, discharge to assess. I've attended a few of those meetings. Normally there are about 20 of us, and at most we talk about 3 or 4 patients. And I'm so proud to say that, because there are 20 brains deciding that that particular discharge to assess is safe. And unless we agree, no one comes out. So there is no movement of people out of the hospital just merely to create space. No, that doesn't happen like that. And predominantly the need is therapy and care needs. The clinical need for these patients are far less than the supportive care they need to be looked after. Few of them will need a bit of oxygen, some may need some insulin, but really it is the social care model which is enabling this to work. And I think we really need to appreciate that. And extremely unwell people don't come into the discharge assess system. So it's really working effectively and safely. And in a way, it's working with the assurance of clinicians who attend and therapists and social care workers who attend these meetings to determine that this is a safe thing to do. And I think you have the reassurance. I personally attend these meetings myself to see what's going on. And I'm very comfortable with the standards they have established in determining the form is not filled, patient doesn't come out. And the form is to be filled properly before the patient comes out. So it's really, really safe. Same with the vaccine program. Again, I've been around the sites. The British Army arrived over the weekend and the public loved them. At times I'm able to vaccinate, but the public say, oh, there's a soldier there, and the soldier grabs them. And well, he stands straight, he's younger than me, looks fitter than me, I can't complain. But it's really going very well. We did 1,000 vaccines, 1,004 to be precise, at the Nelson on Saturday. That was really very uplifting for us, because that is for us 1,004 lives saved. That is for us 1,004 people who could have gone to St. George's but don't need to go to St. George's, which means those nurses don't need to break their backs. We see the full story, and that's how we approach the vaccine program, and it's going well. Always we'll have hiccups, but I rather not talk about hiccups. To me, it's a success.
So Vasa's leaning into my second part of my
Sorry, don't want to steal your thunder.
Vaccination. Shall I do that and then take questions?
Go for it.
Questions at the end. And also we do have Mohan, Vasa, and Karen with us, who are are clinicians on the front line here. So you can absolutely get their input. So just to say that all the Merton centres are now up and running, as Vasa said. We also have Army vaccinators supporting the Wilson and the Nelson. We're focusing on the priority 1 to 4, and we are confident that by mid-February, the 15th of February, as are the government pledges, that we will have vaccinated those cohorts. We are also looking at health and social care staff. And we have large sites coming online towards the end of February, particularly kind of in Merton. We have some sites already established at the Excel Centre and Epsom, and we are working with those sites and with the sites that are going to be in Merton to make sure that we're not trying to target the same people, and that there is some sort of coordination between larger sites and the PCN sites. Data. I know that everyone's absolutely really keen to get data. So the National Data Capture published its first information last week, and unfortunately it's still at a Southwest London level. But we can say that over 95,000 people in Southwest London were vaccinated. If you speak to our local clinicians, I think that they think that is underreporting. So we are working on a daily basis to make sure that the information comes as quickly as it can into the central data set. But we do need to keep refining the data, and particularly around things like ethnicity and take-up, etc. Some local information, certainly around care homes. We believe that we've gone about 80% of our care home residents are now vaccinated. So that's quite a high level. I think one of our challenges is care home staff coming forward to get the vaccination. And so Mohan mentioned some webinars. We are doing care home staff webinars as well to try and dispel any any worries, any anxieties, any thoughts about not taking up the vaccine. We have a long presentation here, but that basically kind of gives you this the summary, and I'm happy to line. Vasa. Oh,
Vasa, did you want to come in, or are we going to kick off?
Comment, but I'll let the questions come and then I can come in.
Great. Okay. If I go to Una on questions then.
Thank you very much. And that's really very interesting, but also very uplifting to hear some of that data coming through. And you know, it's fantastic to hear the rollout of the vaccination. I know personally that people are really, you know, relieved to get their vaccinations, and we're now into some of the over 70s. I'm aware of that, so it's really terrific at the pace that we're going. I have had some questions though about, and I know Dagmar knows this, on larger sites and in Merton, because whilst we are doing so well with Wilson and Nelson and so on, there's still some people wanting some comfort that, you know, as to where these might be coming, I guess. So I am being pressed on that. So I just wondered if there was any further update. And just a bit earlier in the thing, I mean, I'm sounding, yeah, really comforted by the fact that we have such a good discharge into Merton and Wandsworth and all of that. But obviously, discharge into care homes is still a concern. So, and obviously our care home numbers are not fantastic. So I just wanted a bit more knowledge around that side. But it certainly sounds that we're on a very good path, and I'm pleased to hear that, despite these terrible deaths today. So thank you for all what everybody's doing, really, I think.
So I think my
thank you. Oh, Mark, I think you come back a bit now.
Thank you. I think we can provide reassurance that discharge to care homes is being done in a safe and structured manner, because we're not discharging to every single care home. We are not even discharging to all of a care home. We are discharging to part of a care home, which is operating as a separate entity to rest of the care home. So there is strict guidance and specification on, there is no free movement of staff from one floor to another. There is no free movement of person from one floor to the other. So they are being operated by the businesses as separate entities. And that is actually the only way I can tell you, sitting here, that I'm satisfied with what we are doing with our discharges into care homes. And Mark alluded to the second care home, which will be coming, though it's in Sutton. It's actually 100 yards from my practice. So and therefore Merton should be proud that Merton clinicians will be looking after not one but two care homes where people are being discharged from the hospital, provided the second one comes through its infection control survey.
Thank you, Vasa. I know we have Hannah on the line as well. I don't know whether you wanted to comment on the care home discharge.
Thank you, Chair. I did raise my hand. I'm sorry if you didn't see it. So yes, I just wanted to come in on those two really, really important issues. And just going back to Mark's earlier update around what we call these TADs, these designated places of safety. Merton was one of the first boroughs to set these up. And actually the reason for setting them up was to make sure that anybody that was ready for discharge, going back into a care home environment but was testing positive, would go to this alternative destination and do their isolation there to ensure we protected the other residents of the care home. And this was very new to us, and we set this up very quickly. But I think what we learned very quickly is when the system comes together, health, social care, home, the care home providers and managers, amazing staff, and our local GPs. We got this off the ground really quickly and safely. It's also subject to CQC registration, so we were not allowed to operate unless it was inspected, and that included infection control, and of course we were guided by our public health colleagues on that as well. So Una, our commissioning team works very closely with Mark's team and with the care home managers and providers, and I'm assured, because we kind of monitor this daily, that we're not discharging people into care homes that's testing positive. They are going to that designated place of safety. And it's something, as the Director of Adult Social Care and all directors of adult social care across London, we monitor it daily, because we have to learn from outbreak 1. So I would just like to kind of confirm that assurance to you. I think it's a really important point. Thank you, Chair.
Thank you, Hannah. And I also just wanted to ask whether Mohan or Karen wanted to come in at all on just to provide any comment on the vaccine rollout before we move on to further questions. Karen?
Yeah, I'd just like to echo what Vasa said earlier. I think it is going really, really well. It's been a massive effort. Just talking about the care homes in particular, I think we did really well in Merton. In fact, the most recent local data is that we've done 88% of our residents in care homes, which is a really good level of achievement. And we're now looking at what we call phase 2, whereby we're revisiting. Some patients may not have been vaccinated if they tested positive in the previous 28 days, for instance. So it's not just a single visit and that's it, all done. So we are actually looking to keep going with that until hopefully we've done every single person, but we've made a really, really, really good start. The other vulnerable group that we're starting to focus on is actually our housebound over 80s. We need to remember them, and our practices are all setting off with their cool bags, etc., to go around and do their home visits, and we've got the option of some support from our community services to help with that if needed. So we did do some housebound overlapping with the care homes, but now the care homes are more or less finished, apart from some revisits. We're really focusing in on our housebound over 80s, so that's underway. The next thing that we're really starting to look at is that we're asking all of our practices to do in-house searches, so that we can really try and get practice level data, because I think it's really important that we don't just look at percentages, because they can obviously, their averages generally, they can hide sort of high and low uptake. So we're actually going to drill down now and look at our practice level data to identify if there are any practices that may need additional support. Colleagues mentioned some of the outreach and the webinars. If it's particular populations related to specific practices, can we support them? And even we would potentially have the option now with the AstraZeneca vaccine of running some practice level sessions if necessary to target those particular populations. We have worked out that our run rate through our 2 main sites is adequate to meet the Prime Minister's target, but that wouldn't stop us going out and doing other sessions in local practices if our data sort of suggested that might be another way of getting more people vaccinated. So those were really the extra sort of bits that are really sort of hot off the press over the last couple of days, really, and how we're sort of flexing our model to try and get to as many people as we can.
Thank you, Karen.
Thank you.
Mohan, did you want to come in, or shall I?
Yeah, I just got a couple of comments really. It was just on what Vasa said about the army. It's not only the residents who have welcomed their entrance as well. I think some of the staff have enjoyed their presence on site as well, and it's really lifted everyone as well. But actually, it's been a pleasure. So I've been on site where I've been working with the army. It's been brilliant working alongside the army. You know, how often is that going to happen? And so it's really lifted morale, and the morale's great in both the hubs. The volunteers, again, are really fantastic. We've got 51 volunteers, and on any one day there's about 21 volunteers are coming in day out. when the shifts go up or when the clinics go up, they get full very, very quickly. So, things are boding well, and I think that reflects in the results we're getting. We've got a very high numbers of patients who have been vaccinated. So I'm reassured myself as a GP that we're doing what we can, all we can, to really get our residents vaccinated. So yeah, that was it. Thanks.
Thank you. I think we've got Mark back with us, so I'll let Mark go first, and then I saw Ellie and then Vasa.
And apologies, I seem to have a really unstable connection, so apologies for that. Just picking up on our plan for the last week in February in Merton, there's 2 of them. We don't widely publicise them. We have had issues about people just turning up sort of where they're not they haven't been asked to come along for a vaccine. So that we do have those planned, and we are anticipating it the last week in February they'll go live.
Great. Ellie, and then Vasa and Hannah.
Thank you, Chair. And my question is also about vaccinations, and I've had nothing but positive feedback from people who've been involved. My mum is only 72, doesn't have underlying health conditions, and was invited to the Wilson last week. She was mainly upset that the army turned up after she'd been there, so she didn't get to have that opportunity. But my question's about the phrasing of, we talked about vaccines being offered to this number of population, and we've talked already a little bit about some people choosing not to take up the vaccine. And I heard today of an elderly couple I know who are late 80s and really should take it, and they don't want the vaccine for some fairly spurious reasons that I think if a doctor spoke to them would be able to reassure them. At what point a GP is going to start, or is anyone going to start kind of going back to people that have been offered and haven't taken it up and having those conversations?
Vasa, Vasa and Karen, did you want to come in on that? Oh, Vasa, I think you're on mute.
Thank you, Chair. That is the question of the day. How do we reach out to people who have currently said no? So that's where we all have a part to play. And yes, dear doctors, when we do our search and find people who have not been vaccinated, if it is due to a decline, a soft decline, we need to work on the soft declines. And in England, we have more soft declines than the hard declines you see in some other parts of the world, because our conspiracy theories society is not that such deeply ingrained. Ours are where social media is hampering people's rational thought processes, and they are getting fears which are, I think, genuine fears because they're being bombarded with misinformation, but they're not ideologically driven. So I have a lot of hope that we have to work on this, all of us collectively, and we can move people. And I think we all have a part to play with that. Yes, doctors have a greater part too, and that's where our webinars come in. Our webinars are not lectures. Before I came on this, we had a 2-hour meeting with people with a history of mental illness. We have met people who look after people with learning disability. We have reached out to people, various people, and I think each one of those cohorts are extremely vulnerable, but they are being frightened by what they have heard, and it's by allowing them to ask the question and then answering the question they raised is how we are gently moving people. And I'm actually at every webinar I do, at the end of the webinar, I feel convinced that at least I have changed 10 people from negative to neutral or positive. And I think we just have to keep on working at it, but we have to work. And the group I really worry most about are the people working in care homes. We have a lot of work to do with our care home staff. All of us need to make a lot of effort with that group because they look after our most vulnerable people.
Thank you, Vasa. Karen, did you want to come in?
Yeah, I think Vasa's probably covered it, but I mean, I think that's where we really want to see the practice level data, and it's really important. It's not a one-time offer. We need to be offering repeatedly all the way through the program. Again, also, it's not you've sort of missed your cohort. I think we need to be continually looking at the cohorts and understanding why people may have changed their mind, or actually some people may have actually been unwell at that time and not able to have it. So, but they may still, want it when they've recovered. So I think it has to be an ongoing approach, not a single invitation or you've missed the boat, so to speak. So it will be a process of over a period of several weeks and months, I think. But I think we've cracked the bulk of it, which is really important for developing immunity amongst our amongst the wider community. But I think we need to keep going.
Thank you, Karen. And Elliot, an important point about vaccine hesitancy that I believe Dagmar will also be covering in the next agenda item. Mark, did you want to come in?
I just wanted to add that I think we do this on a number of levels. I think there's the individual, which we can do from a practice level, but then actually we are also targeting communities, and we're doing that via webinar, but also with faith leaders, etc., to try and get those messages across. And we are, I think it's a continuous kind of message that we keep needing to get out there, and we are taking our clinicians, because I think clinicians saying the message on a number of different levels.
Thank you, Mark. Hannah.
Thank you, Chair. I just wanted to mention, for the purpose of the board as well, just another level of reassurance around the vaccination programme and the commitment from our NHS colleagues to ensure access for those frontline critical social care posts that's working directly with vulnerable children, adults, people in supported accommodation, and of course our housing colleagues that's out there in the front line working with our homeless population. We are targeting those, and the uptake has been absolutely excellent, I'm pleased to report. And actually it has really boosted morale. You know, this is third lockdown, our staff are a little bit weary, and just that vaccination programme being rolled out, and the same power with our NHS frontline staff, now social care staff alongside them, I think has really boosted the system. So very grateful to our, especially our South West London NHS colleagues, who's really worked with us very closely to find our way through the famous JCVI list to make sure we were all abiding by the rules. But it's worked incredibly well for our council staff, and I just thought that was really important that we let the board know that. Thank you, Chair.
Thank you, Hannah. Do we have any, Brian?
This is very quick and maybe very silly. And it doesn't help anyone's cause. I read today about the German health people saying that the AstraZeneca vaccination doesn't work on older people. I mean, I'm assuming there's nothing much in this, but you know that doesn't help Vaz or anybody else out in the community who's persuading people. Is there any line on this, or are we going to dispute it, or it's probably for Mark, really? I don't know. It's for the.
No. So good news, Chair. No one has asked me. Because I think my patients, know far more than following these unnecessary media stories. I must declare a conflict here. I did a home visit on Saturday night at 9 p.m. I gave 2 elderly couple their vaccine at home, and the lady of the house gave me some milk rice. Milk rice traditionally in the ethnic communities is what they give you as a positive gesture. Dagmar, I don't know if they've broken any lockdown rules. I did have dinner there.
Shall I very briefly come in as well? So, Brian, I think, again, how information gets very quickly distorted. I think it is absolutely the right thing that we continue to study the impact and efficacy and safety of the vaccine, and that happens big time in this country with the Pfizer vaccine, with the AstraZeneca. You might have seen there was quite a big article of the professor who leads the Oxford program. It was all over the BMJ as well, to actually help us to understand what vaccine development is. This is the normal process. So we've got the MHRA, our regulator, that has pored over the studies to release the vaccine, showed the efficacy. There are studies on older populations, but once you roll out, you don't stop, and so there's continuous surveillance. And our national CMO is working across the whole of Europe with his colleagues, so that we really work together and collate the data. As far as I know, and obviously changes come quickly, there is no indication at the moment that there is any safety or efficacy issue that has newly crept up. You will have remembered that when the Pfizer vaccination started, there were 2 cases that had a relatively mild but nevertheless anaphylactic reaction. That filled the media for quite a few days. It was put into perspective. It was not unexpected. It was properly monitored and dealt with. And that's what we're continuing to do. So I wouldn't say we need to shut this down. I think we need to engage in a scientific way.
Thank you, Dagmar. And I know that you'll be picking up on sort of engagement and messaging to a certain degree in the next agenda item as well. I just wondered whether I could just ask 2 quick questions which link back to the points that Ellie was making earlier. And I know that we don't have the specific data, but I just wondered whether we have any indication on the numbers who to date have been refusing the vaccine across the borough. Yeah, just to date, and potentially sort of a breakdown across age groups if that's available. I'm going to take that as Dagmar.
Briefly come in. What is fair to say, and I think Mark alluded to it, the data is quite complicated. Now that's a little bit of a pathetic sort of statement, but it also reflects the truth because it is quite a complex delivery of the vaccine. Nevertheless, a lot of effort has come in to streamline the data. Everybody agrees that we do need to have the data cut not only at London at sub-regional level, but also at borough level. And indeed, directors of public health like myself are starting to receive some of the data. But at the moment, I am still bound rightly by some restrictions because they are not complete. And what we want to avoid is to release data that are clearly incomplete in order to avoid that people jump to really the wrong conclusions. But we are on the way of getting data sets that will be shared and that are at borough level. And you are absolutely right. What we need to understand is, as Karen said as well, at practice level, at borough level, to have granular understanding who takes the vaccine up, who refuses, for what reason. And obviously, the care homes, that is still a relatively compact group that I'm absolutely confident we will get a handle on very quickly. So it's a little bit of holding out for it, but hopefully in the next subgroup or health and wellbeing board, that will be routinely, hopefully picked up in my regular report.
Thank you, Dagmar. And I'll just let Mark come in before we move on to the next item.
So it's just also to say that I think it's really important that we're all working from the same kind of data sets as well. So across our public health, our local and the national, we are working to make it more robust so that we are not confusing people with different data sets, and that's really important. But as Dagmar says, we're on a journey here in terms of data, and we're all trying to lobby as quickly as we can to get the data that we need, but it will certainly take a little while for that to be exactly where we need it to be.
Absolutely, thank you, Mark. And obviously a very rapid mobilisation of the rollout of the vaccine, so understandable on that point. So I'll just move us on to agenda item 6, which is an update from Dagmar on the Health and Wellbeing Board Community Subgroup report around engagement. So Dagmar, I'll just hand over to you for that.
Thank you, and I'm aware that we are a little bit behind, and I want us to spend a bit of time on climate change as well. So Clarissa, if you wouldn't mind giving me the next slide. So I want to quickly mention our Health and Wellbeing Community Subgroup, and particularly want to get the Health and Wellbeing to agree our future focus. Just brief reminder, Health and Wellbeing Board has set up the community subgroup as a formal part of our COVID outbreak control governance. And so the subgroup formally reports into the Health and Wellbeing Board. So I feel it is important for us as a board to know what the subgroup is up to. And obviously also a big thank you to a number of you who are doubling up and are on the board and on the subgroup. And for those of you who sponsor, so to speak, one of the additional members, connectors, we call them as well, a really big thank you, because they have been dedicated and very active. Reminder, one of the big themes underlying the Health and Wellbeing Board and its community subgroup is we need to listen to our community with a specific purpose to tackle the disproportionate impact. And so the quick proposal, which I think I have no doubt you will agree, is that first of all, the subgroup was set up in the rather optimistic spirit of the pandemic possibly being finished by now, so until the end of March. Now that clearly hasn't quite materialized, so I'm proposing that the community subgroup as our sort of outreach into the community, that we extend it at least for another 6 months and then review. And then the second suggestion is that the subgroup now is going to focus on tackling vaccine hesitancy. And from what I've heard so far, I have no doubt that there is support from you. And for me, it's quite important because it is a resource that we as a board, in a way, have. And in the two areas where I think the subgroup can really help is the reach into the community, for particularly, as we've already alluded to, counter misinformation, but also without prejudice, listen and then feedback so that we really understand what some of the barriers are, rather than jumping to conclusions and sometimes even perpetuating stereotypes that I'm still, avoid to get drawn into. So if you move me on, I've got one other slide, and I won't dwell on it, but when I talk about vaccine hesitancy, it's sort of slipped into the vocabulary rather quickly, this word. And over the weekend, I had so many emails, I can't tell you, and I got all confused, and it was one mushy bucket. So I have tried to sort it a little bit for us, particularly if we're charging the subgroup to work on this, to structure our thinking a little bit about it. And so one first wake-up moment was that actually the reasons why people seem to refuse the vaccine is by no means just about the vaccine. And often we jump to that conclusion, and there's quite a lot of evidence indeed across London that sometimes your refusal is misunderstood as we jump to this conclusion. Oh, somebody possibly from an ethnic minority group doesn't come. And if you dig a little bit deeper and tune in, it is often more around access. So some anxiety about having to go to a place that is not local and is not familiar and is not trusted. So for us to start to consider, and Karen mentioned it already, whether there are possibilities to think about other settings. And I mean, primary care is an ideal setting, people know it. But elsewhere you have seen very successfully some vaccination in face settings, because they've got the space often, and they have the trust. So for me, that was one wake-up moment. Then around, of course, there is quite a lot of issues around the vaccine itself. And for me, what was helpful to think about it was there's quite a number of what we call late adopters. So people who are, I think quite sensibly, to be honest, a little bit more cautious. They say, all right, I don't want to be the first mouse, but it doesn't mean that I'm not going for it. And those respond really well if they see their peers get vaccinated. And hence I was so encouraged to hear that Karen said, you don't have one go and then we move on. We know we have to revisit. The never vaccine rate, so the anti-vaxxers conspiracy theories, actually in all the surveys, those go down. Yeah, they had a time when they captured the imagination a lot, but in some of the bigger surveys, they haven't got quite as much prominence. And then for me, what is really important, and I think all of us can play a role, is that we take the specific questions, potential misunderstandings, uncertainties really seriously, so that we don't belittle them, but take them seriously and think a little bit again. So there's lots of good information now about ingredients. You know, the NHS has tuned in beautifully. There are really good frequently answered questions. There are fantastic webinars about the immune mechanism. I didn't even understand an mRNA vaccine. You know, of course, people think, oh, if it's RNA, then it's DNA, so it's doing something to my genetic code. That is not stupid. That is quite understandable. So really excellent material to explain how it works. Then about the vaccine development, people aren't stupid. It was a quick development. So be honest about it. Explain how it works. And for me, a new thing, I hadn't heard about it, but I've since read about it, is that some groups have some ethical objections, conscientious objections, because there's apparently a history for one of the drug companies, Pfizer, to have had trials in the past. And again, unless we tune in, we brush over and put everything in one bucket. And then side effects are very important. Again, NHS has tuned into that. There's the fertility stuff going on. We already raised some of the German articles. There were in Norway some articles about the very frail. So engaging with the specific issues that people come up, and I think all of us, in a way, collating them. And then another, for me, wake up was that some of the reasons I have listened to had something to do with the consequences of the vaccine. So particularly care home staff, and again, it's anecdotal, but it made me wake up, say, maybe my job will change. Maybe, you know, I will then have to look after all these very sick COVID patients, and I find it so depressing, I don't want it. So if I'm not the first one to be vaccinated, maybe that I will be spared. So that then gives us much more of an understanding in terms how to manage. So I put this together just for us and working with our subgroup to be humble, yeah, and take people serious in their questions. So if we do the next slide. So what we want to do, and what I propose that we particularly task the subgroup to do, is absolutely work hand in glove with our NHS colleagues. There's fantastic material, and as our clinicians said, they have gone out of their way. We have a fantastic webinar with one of the GPs for our staff in the council as well. Really very well received, and we can share this so that we in our networks and our subgroup can use all this already existing material. We've got a strong network of community champions. They are already jumping at the challenge to use their infrastructure. We've got a great voluntary sector. We've got a number around the table. Again, they have got their own networks. And so the request really is, if you give me the next slide, that we agree that we need the subgroup for a bit longer, that we're happy that the subgroup works on whatever we call it, the equal and fair distribution of vaccine. And for us really all to say, how can we support our subgroup members? What can we do as individuals? What can we do as organizations to really have a broad reach? That's sort of in a nutshell how we might tackle this vaccine hesitancy.
Thank you, Dagmar, and really timely following Brian's earlier point on misinformation. So presents a really great opportunity to start developing those messages of reassurance. I don't know whether anyone has any questions to Dagmar on that. Una?
I just wanted to echo support really on a lot of what Dagmar has just said. Obviously I'm on the subgroup and we've been working hard on a lot of those issues.
Yes.
I also attend the COVID Champions meeting regularly on a Wednesday, and that's been tremendous to take part with, and to see the work that everyone's doing really across the board. I would just say though that I think some of the area that would be really good to get into, particularly with webinars and so on, in short messages, would be through to some of the faith groups. And I mean, I'm involved in church, but there's obviously a lot of different faith groups right across the piece, and I just think the more we can get out into those with some of these messages, the better. And for people that have had the vaccine, to also give reassurance that, you know, that they're still walking, they're still fine, and they're not keeling over, and they've, you know, might have had a sore arm or a little sore arm, but fundamentally fine. Yeah, the more we can really do that and see how we can. But I fully endorse otherwise what the work that everyone's, as I say, doing. It's really just a question of, I would totally agree, taking things seriously. It's quite easy to be a bit flippant. I've done that and been pulled up short by somebody on it myself. So I think we do have to treat people with respect when they say they don't want it for whatever reasons. Even if we think it might be spurious, one does have to make sure that you know, give your good reasons. And yeah, thank you.
Thank you, Una. Mohan?
Yeah, I completely agree with, well, first of all, the subcommittee in terms of focusing on certain the needs across the borough. I'm just picking up on the webinar, so I've been on a few myself, and certainly it has been the understanding and giving time. So we've overrun 3 times the last few times because people have had lots and lots and lots of questions, and so they want to be heard. And actually some of them are quite simple, or perceived to be simple, but actually they're not for, obviously, the recipient. In terms of faith groups, yes, we've been, a lot of the faith groups are starting to get involved. I went to my local temple, which I've been there since I was a child, and did a sort of bit of a spiel there. And I've also engaged some of the Muslim mosques as well, who are also doing it now as well. So I think that's also a powerful message as well. We're doing a webinar this weekend with a lot of the faith groups. So I think it's all these messages, giving the right information, so we're not sort of shoving down their throat or forcing them, but actually they can make that informed choice based on the facts and not a myth which they've heard from someone down the road. And I think the more messaging we do, the better. I don't think you can overdose on messaging. I think the more repetition, people feel comfortable and feel safe. So I think we're in a good place for that. So yeah, thank you.
Great, thank you, Mohan. Ellie?
Yeah, thank you. And I think I used the word spurious earlier for some of these reasons for not wanting a vaccine, so I'm giving myself a slap on the wrist. But I've got another reason to add to your kind of bullet points of kind of legitimate concerns that people have. That the people I know, they were worried because they're already on lots of medication. So their concern was the vaccine is something else on top of complicated medication. So that's a kind of another key message that needs to get out. I think it's brilliant, all the webinars and work that's going on. So proud of the kind of young community champions and all that work. I suppose what I still worry about, and this might be a question to pick up in the subgroup with Rob in particular, is, you know, all those older people who aren't on webinars and who may just still be sitting at home with these concerns.
Thank you, Ellie. Vasa?
Thank you. Thank you, Dagmar. You have highlighted all those difficult questions I faced in every single webinar I attended. And what I have learned by all the webinars I have done is those PowerPoints which I took with me are a total absolute waste of time. Those PowerPoints address my learning objectives. They do not address the learning objective of the people sitting in front of me. And I think what we should do is bin those PowerPoints and then throw the floor to the audience and say, okay, you start throwing the bouncers at me and let me see whether I can play it back at you. And I think we got to answer the questions in the minds of those people who are hesitant. And they are genuine concerns. I don't know about you. Mohan's younger than me. In medical school, he learned about DNA and RNA. When I went to medical school in 1981, I didn't learn much about DNA and RNA. And so we can't then blame others for not understanding the difference between DNA and a fragment of an mRNA in some dead vaccine. And I think we really need to understand where these fears come from. And for a young care worker in a nursing home, fertility is of absolute, I don't care much about fertility, but for that particular person, fertility is absolute paramount importance to that person. And I think we really need to, you actually get the whole crib sheet there, Dagmar. Those were the most difficult questions I was faced with. And the thing about interaction, so if you got serious mental illness and you're on injection every 3 weeks, the last thing you want to do is for me to come and give you a shot and then to destabilize your mental illness. It's an absolute genuine concern. And also, to be honest, Dagmar, those people on 3 weekly depot injections were not part of a randomized controlled trial. So then I have to explain that in a different way. Science doesn't work, but a bit of logical reasoning does work. And I think we need to do more of these outreach. And we also need social distancing stops us from meeting people face to face. We also need more legitimate champions. Mohan, I know how bad his Tamil is. Mine is better than his. And I think we need people who can connect with the public in a way they actually trust you. And Mohan doesn't mind my jokes, but I think we really need better champions than him to reach out to the Tamil community.
Thank you, Vasa. Mohan, did you want to come back on that?
Can I just come back? Vasa, I'll give you a tutorial later on MRA and yeah. But actually, I think some of the webinars I've found, and it's been quite a recurring theme, is actually the younger patients or younger relatives, Eleanor, who've been telling the elder that they not to take it. And so the elders actually want to take it, but the younger ones saying don't do it. So actually, I think it's all that piece, which I found that really fascinating. That actually the younger group were telling them not to take it. But yeah, that was what I wanted to add. And Vasa's offer of a webinar. Thanks.
Thank you. Were there any further questions or comments to Dagmar on that point? Great. Well, it sounds like we have a lot of support to extend the subgroup for another 6 months and for the priority focus to be on vaccine hesitancy. Can I see any dissent to that? No, so I think that's all agreed. Perfect. And then just moving on to our last agenda item of the night, and I think we've talked about COVID a lot over the course of this evening, but previously, and we talked in this meeting about how it's exposed sort of a number of inequalities, but also the sort of importance and the role of the wider determinants of health, of which sort of climate change, air quality factors in. So I'm really glad that Chris is here this evening as a sort of permanent member to talk through the climate strategy. So I'll just hand over to Chris.
Thanks, Rebecca. And I think there's some slides that Clarissa will just load up. I've only got 5 slides, but it was just a supplement to the paper that I'm sure colleagues have read. So the aim of the report this evening is really just to remind colleagues of the Council's commitment to climate change and to seek the support of the Health and Wellbeing Board. If we go on to the second slide, please, Clarissa. Just a reminder, really, in addition to what you've got in the slide in front of you, some of the key milestones that we've already passed. In November of last year, the Council adopted the Climate Strategy and Action Plan. And just a couple of weeks ago at Cabinet, the Cabinet agreed the Year 1 delivery plan to go alongside that. And tomorrow, a very significant milestone is the first meeting of the Climate Action Group, and that's a community-based group which will move us much more into the delivery mode now, because the analysis, the planning, the preparation is largely done. We know what our footprint is, and we know what needs to be done by and large in order to get us to our objective, and I'll talk about that in a moment. Some of the action has already been taking place in parallel, but we now move very firmly into the delivery phase, and that's why we're seeking the support of the Health and Wellbeing Board and bringing this paper tonight. The two key dates for the council are 2030 for us to get to a zero carbon position as a council operation, and 2050 for us to get to zero carbon as a place, as a borough. The council contributes about 2% of the emissions in the borough, so 98% is beyond our direct control. And that's why this is essentially a behaviour change programme, by and large, as well as some infrastructure change, but most of it is about behaviour change. And in preparing for this presentation this evening, I was struck even more that this is essentially a health plan. And that's why it's so important to the Health and Wellbeing Board, really, because the outcomes of not tackling this are, well, the existential threat on all of our health, on the health of all of us, but all of the actions that we will be taking, as you can see within the plan, are about the co-benefits of them are much better health, and you can see that very clearly from this slide here. So the first one around tackling fuel poverty, a lot of action in our delivery plan around retrofitting housing, tackling all of the issues around our building stock, and reducing air pollution as a consequence with the health benefits that flow from that. You can see from the left-hand side how the actions of the delivery plan knit in so closely with the outcomes of the health and wellbeing strategy and the common aims and the co-benefits that flow from that. So we've got a lot of work that's already taken place in the borough around transport and shifting towards active travel. Just last year, or in the last financial year, we've spent around 1.2 million installing more school streets, low traffic neighbourhoods, cycling infrastructure, and really trying to tap into the change in behaviour around transport. There's been less progress on decarbonising the building stock, and we know that there's around £2.7 billion needed to invest in the borough's housing stock in particular in order to get the change towards zero carbon housing, with the 80,000 boilers almost certainly needing to be replaced. But the returns in terms of health benefits are significant in terms of reducing fuel poverty, warmer homes, lower bills, and the improvement in the quality of life and the health of our citizens. And we also know that shifting from gas boilers will also promote a cleaner and greener borough and less nitrogen oxide in the atmosphere. So lots of work to be done. If we could move on to the next slide, please. What I also recognise is that the NHS has shown massive leadership and has already established very ambitious targets. The first health authority in the world to set out their zero carbon objectives. And I don't need to remind NHS colleagues, but it's worth just saying that the objective is to get to zero carbon for their own internal carbon footprint by 2040. Those are the green wedges on the slide there. And to get to zero carbon for the supply chain by 2045, recognising the significant work that will need to take place in achieving that blue side of the pie chart in front of you. We know that the Merton's estate strategy will hopefully aim to achieve net zero targets over that period as well. And I was very impressed with some Katie Holter, who's on the call, who's our climate change officer, had sent me through some really useful BMA and NHS webcasts describing the work that they were already doing across London in order to be greener and to work towards zero carbon. So moving on to the last slide, which just sets out what we're seeking from the board this evening. So as well as understanding and supporting us in the delivery of the delivery plan that's already agreed by council, and that includes a lot of existing collaboration with health colleagues. What we're looking to do is see if we can build on that to seek the involvement of health colleagues in the climate action group. That starts its meeting tomorrow, but we expect that to run for some considerable time. To look at a joint statement of support to get to zero carbon, work collaboratively across the health and local authority piece to achieve those zero carbon targets. Look at maybe developing some shared communications activity and some work on our estate strategy, where we know there's going to be some heavy lifting over the coming years in order to change the carbon footprint, particularly around the Wilson Hospital, for example. And just moving that to, in the longer term, look at how we can better collaborate around fuel poverty and the behaviour change projects that we know will be absolutely essential for the reduction in the consumption carbon. We've struggled to estimate the amount of carbon that's generated from the consumption side of the equation around carbon, but we know that it almost certainly outweighs many of the other aspects of our carbon production in the borough, and there's an awful lot of work that needs to be done there around the behaviour change necessary, again with significant co-benefits around diet and exercise, particularly for young people. So I'll close there, Chair. I'm indebted to Katie, who's, as I say, on the call here, and between Katie and myself, happy to take any questions or comments, Chair. Thank you.
Thank you, Chris and Katie. A really ambitious strategy, and also great to see both on the screen and also in our papers the sort of low cost, low resource actions that can be taken forward, as well as those sort of longer term ones. I wonder if anyone had any comments either on the objectives themselves or how we might be able to sort of support the delivery of those objectives and taking those forward. Vasa.
Thank you very much. And I have no doubt, as much as I believe that long COVID is real, I also believe climate change is real. I also believe that climate change really impacts on the life of my patients, especially my older patients, my patients with lung disease, my patients with heart disease. For them, this is a real problem, and it really affects them. So I think our children with asthma, they're also damaged by the environment they live in. And that affects their schooling, that affects their future employability, that affects their social mobility. So really, there is no opt-out clause for any healthcare worker out of the climate change discussion. Well, not one for Merton, because then they fall out with me at that point. As far as I'm concerned, I'm totally behind it. Sorry, Mohan. I don't know what your view on this is.
Thank you, Vasa. Dagmar.
Thanks very much. Absolutely I'm delighted. I think as a Health and Wellbeing Board, there's something other than COVID that we, I think all die to get our teeth into. And for me, there's quite a bit of learning as well, how we've pulled together and worked as a community on COVID. Now, COVID was obviously an extreme, immediate risk that came upon us. But there's something for me in terms of learning and comparing that with an also extreme, but not quite as immediate risk that climate change has for all of us. And I think possibly the COVID experience of a community can inform how they find together for sort of climate change. 2 points. As a Health and Wellbeing Board, our absolute commitment is around tackling inequality. So I think for our climate work, that has to be an important focus. We do know air pollution, for example. There is the classic distribution that in the poorer bits of the borough, where there's actually less car ownership, often the air quality is worse. So the brunt often falls on the least well off. We have to pay attention to that. And then secondly, again, our principle working with the communities and the strengths of our communities. We have got a lot of experts, to be honest. If you think about that community action group there, it's full of experts. We've got a voluntary sector that is vibrant around sustainability. So tapping into the enthusiasm, knowledge of the folks caring for Merton, really important. And lastly, obviously, I have to mention our young people, because it is their planet and their future, and we can't mess it up. So they have to have a really loud voice. Thank you.
Thank you, Dagmar. Una.
So again, I just wanted to praise some of this work, and actually, again, though, I would say that in a sense, one has to talk about some of the respect given to people with differing views, and because otherwise, again, you can come up just again. And I think behavioural change is something that does take a while. There's no doubt about that. But I guess that some of the effects I think we've all seen is the pandemic's been dreadful, and it's hit all of us really hard. But you could say that there have been some benefits, in a sense, to some of the behavioural change that's come through because of it. And it's been quite quick, because a lot of people have taken to their bicycles or actually realised that they need to do this, that, the other. With some people's household economies shrinking, they're actually realising that they can make changes that will affect them, not least putting on extra jerseys or whatever it is in your household. And so I think there is work that we can all do to help move people forward with it all. Certainly it's going to take more than just a few behavioural changes, but I am seeing quite a change in people. And certainly the next generation are very much getting on their bikes. If my sons are much to go about, none of them have bought, not even got their driving licenses, yet alone get a car. So I think that, and I've got three in very different areas. Well, one of them's a carer, and he goes off on his bike every day. And it's quite fascinating, I think, to see. But I also think it's fascinating in my own area of people actually ditching cars, getting onto bikes, or moving to different type of where they do need, and some people do need a car, moving perhaps to different ownership types and different ways. And Merton's been really good, I think, in bringing some of that. There's a lot more to do, particularly with some of the electric vehicle and on-street mobilisation of that. But there's a will, and I think we need to harness that on the wellbeing side. So lot of work to do, but I think we can hopefully achieve some good cross-party and a good different support to get there. Thank you.
Great, thank you, Una. Were there any other questions or comments to Chris or Katie? No, okay, just one. Oh, Jane, sorry.
I think I was just going to say, not only will it be really good, Dagmar, to hear young people's voices, but I think they'll be real advocates and champions for us in this, because I think that it's something that's really, that there's already a momentum going in our young people across our schools. So we really want to engage them and have them as part of this agenda.
Great. Sorry, Ellie.
Just one more point of that. Yeah, my understanding is that young people have really been involved in shaping it, and now they've got to be involved in holding us to account on doing this. And I think when I talked about it at Cabinet, I used some really cheesy line about how children are the adults of the future. But if Dagmar says similar things, then I feel that I'm in good company. I couldn't agree more.
Thanks, Ellie. Brian, did you want to come in, or did I misinterpret away? No. Great. And just Chris and Katie, I suppose we've seen sort of commitment across the board, and also knowing sort of the NHS's net zero targets and VAS's commitment on this call as well. Just a question about how we sort of keep the conversation going, particularly around these sort of short and medium term objectives.
Yeah, thanks, Rebecca. And just reflecting on the comments, I'm very grateful for those and the commitment and support that's shown. And just a couple of things, I don't underestimate the challenge to the NHS in particular, because I was watching a video about the carbon footprint of a Ventolin inhaler for asthma, and shifting over to something which is less carbon intensive must be enormously challenging. And that's just one example of a medical device that produces carbon because of I think the fluorocarbons used in there. And just reflecting on Councillor Moulton's points around the change that we're seeing, I think we are seeing that more in transport at the moment, and that's really helpful. And particularly in young people, a shift around consumption and diet change, more to meat-free diets, and that's something that, as a health and wellbeing board, I know we would support and encourage because of not just the benefits in terms of health, but the impact in terms of carbon production of that meat-based diet. And that's an area where across the council we're looking to staff to pledge to change their behaviour and change their diet. Just small steps so that we can move forward. In terms of keeping an eye on this, to come back to your original point, Chair, I would suggest that maybe we have an annual report at least back to the Health and Wellbeing Board, where we can both show the progress that's been made, but also look at, particularly as the Climate Action Group makes its progress, we can look at those areas of activity that we would want to seek support from the Health and Wellbeing Board in particular, in order to get the further momentum that will be necessary in order to get to the tipping point and to really start to get the traction needed in terms of the behaviour change across the borough. Some of this will need enormous investment, and leaving that to one side for a moment. Some of it will be about small behaviour change, which is within all of our grasp, but just with our momentum and our collective leadership, we'll be more able to achieve that.
Thank you, Chris. I know we're just at sort of the start of this journey, but a huge amount of support and incredible sort of ambitions in here as well. So thank you for presenting that tonight. Oh, sorry, Katie. Apologies.
Sorry, I just wanted to very quickly add, yeah, thank you all very much for the comments. Just to say that it was lovely. I looked through the registration for the Climate Action Group and saw a few GPs on there who are climate champions. So thank you very much for advocating the Climate Action Group. And also just wanted to say that if you identify opportunities where we can help, so we have a reasonable amount of experience on some of the decarbonisation that some of the organisations like the NHS will need to do. We'll be more than happy to wade in if you want to connect us into the right places. Thank you.
Thank you, Katie. And just looking at the recommendations of the report, we sort of noted and commented on the climate strategy and action plan, and also I think there's been a lot of support on the board to support the delivery of those objectives. And in terms of the sort of short-term and medium-term actions, I think the conversation will be kept open, and that we'll have sort of semi-regular reports back on the delivery of that. And that sort of brings us to the end of the agenda, slightly earlier than usual. I don't know whether anyone had any final comments or questions. Simon?
Thank you, Chair. Yeah, great meeting and good presentation, so thank you. Just wanted to pick up 3 different points with the sort of slightly wider wellbeing lens on it, and I suppose a view on behalf of the voluntary sector. First thing, Mohan mentioned having the army lifting morale. I've done quite a lot of work with the army and young people, and you only need a few of them on site to normally lift things. So, but I think importantly, in addition to them, in a way, as a set of volunteers, the volunteer layer that we've got is still very healthy in the borough. I mean, I know Rob, continues to have an army of volunteers, and Mohan's quite right. Their contribution remains huge in this time and any other time. Chris also mentioned the business community, and I sit on the panel with Diana Sturck and the LBM team. And I think just maybe Hannah can pass it back, possibly. The LBM team are doing a lot of work to try and get funds to support businesses as quickly as possible that meet the regulations. And I think Merton's really doing a great job, because that does have a very direct wellbeing impact on people in the borough and sort of community level, etc. And the final thing, just to let really the board know, we've got it's our 20th Merton Giving panel tomorrow, and we've got a healthy 10 applications. And just picking up on a lot of the things that have been said, there's a great diversity of everything from sustainable food. We've got brand new charities that we've set up that are going into certain communities and supporting them. There's laptops going out with the digital inclusion agenda that I know many of you are keen on. So, and luckily, again, with the support of London Borough of Merton in particular, but also Wimbledon Foundation, Clarion Housing, Moat Housing, who have all, including one today, have recommitted for the current phase. So we've got great support in the wider community to get funds to organisations that are doing really important work for a lot of vulnerable people that otherwise quite simply may have to shut up shop or just not be able to function at the moment. So it's a sort of form of thanks really from the voluntary sector that level of support from the health side, from the borough is allowing us to keep the voluntary sector vibrant and the volunteer network vibrant. So it's a thank you to all for that. So thanks, Chair.
Thank you, Simon. You're absolutely right. I mean, we're incredibly lucky in Merton to have such a diverse and dynamic voluntary sector. And I think we wouldn't be able to continue to support the delivery around COVID-19 without sort of the critical support from the voluntary sector. So I think our thanks to you as well for that. Were there any final comments or questions from anyone? I wish you all